So we are going to shift gears a bit with lots of diabetes. And of course, the second most commonest endocrine disorder would be thyroid disorder in the society. I'm sure it's the same in India. And we will talk about in 20 minutes. I'll try to give you an update on hypo and hyperthyroidism and to, a little bit of physiology to start with. The the hypothalamus-pituitary thyroid axis and the peripheral conversion of T4 to T3, which is the active hormone, and the feedback loop, you all remember. This is important to note if you, refresh your mind how the thyroid hormones are in your blood or the serum. This becomes useful when there is a sort of tests are not matching with the clinical picture. So let's get on with the hypothyroidism. It's very simple diagnosis as shown there. Subclinical when the TSH is raised and the free T4 is low, and both high TSH and a low T4, you have a diagnosis. Causes, it's mainly Hashimoto's thyroiditis or chronic lymphocytic thyroiditis in our part of the world, and I'm sure with universal iodization of salt, the iodine deficiency as a cause has come down to less than 25%. Still, there is drug-induced, lithium being the most notorious agent, and of course, postpartum dysharmonogenesis and other forms are there. Congenital hypothyroidism, I don't know whether there is universal screening in India. In Sri Lanka, we screen all the newborns with a TSH. And secondary, very rare, pituitary and hypothalamic causes. You have to think when you get abnormal results which is not matching with your clinical picture, think about all these rare causes. But the commonest is the autoimmune lymphocytic thyroiditis with antibody positivity. In our part of the world, I think there is 5 to 10% of the normal people also will have the antibodies positive. But in Hashimoto's, it's 95% positivity for the thyroid peroxidase antibody. Predominant in females, we don't know exactly the reason, 8:1, and it can run in families. So as a general physician or somebody in your day-to-day diabetes clinic, in whom should you do a TSH? If there is a clinical suspicion with the clinical features, strong family history with antibody positivity in the family, patients with other autoimmune diseases, and newborns of mothers with thyroid disorders, or universal screening and head and neck irradiation, radioiodine treatment, and some syndromic patients that you might see occasionally. Cold intolerance, constipation, dry skin, loss of hair, you name it, from head to toe, you will get so many signs and symptoms for hypothyroidism. If you see a patient with clustering of these symptoms, because these are very common symptoms which could be due to many other causes. But if you see some of these symptoms coming together, you should suspect. And some of the children or patients with these syndromes and type 1 diabetes. Nearly 12 to 24% in female type 1 diabetes, prevalence of hypothyroidism, autoimmune thyroiditis, and about 5 to 10% prevalence among this thing. In Sri Lanka, we yearly screen all our type 1 patients with a TSH, but you could take a clinical call and, occasionally you should screen them. And sometimes in your day-to-day practice, unexplained hyponatremia is you do the thyroid functions, it would be hypothyroidism. Macrocytic anemia, no other cause found. Of course, B12 deficiency, the more common things are there. Think of thyroid. Hypercholesteremia, very high levels. High CPK, vitamin D replete, no other cause. High CPK, mild hyperprolactinemia. I have seen expressible galactorrhea in people with severe hypothyroidism. How do you get hyperprolactinemia? TRH stimulates TSH in the pituitary, and it also stimulates prolactin in some patients. So you get a hyperprolactinemia. Don't go and do MRI pituitary. Think of thyroid first. So the diagnosis is mainly clinical and it's very simple testing. Please don't miss a lady like this, mixed severe hypothyroidism, what you call as mixed edematous, soft tissue swelling, carotenemic. You won't miss a person like this, or a macroglossia occasionally that you might see. Even telltale signs like this, xanthomata, severe xanthelasma with associated with hypercholesteremia could be a thyroid problem. So pericardial effusion, these are all very rare, less than 1% I am showing. This is a severe pericardial effusion, 1 month of treatment with thyroxine resolved. So these are all rare presentations. And if you happen to see young children, please don't miss somebody like this, or earlier you have to catch them to prevent cretinism, which is a disastrous thing for the child, lifelong of suffering with poor brain development. So, ladies and gentlemen, if you take the algorithm, TSH is fine. I think all of you have the third generation TSH. Start with the TSH. If the TSH is elevated, you could measure the free T4, and that is low. You have primary hypothyroidism. Antibodies are positive, thyroid peroxidase. You have Hashimoto's, that's the commonest. You replace thyroxine. If that is negative, could be another cause. We have the list of things, still you replace. If the free T4 is normal, you end up with subclinical hypothyroidism, where you'll have to decide whether to treat or not. Commonly, if the antibodies are positive, you could treat, or whether there are other signs like high CPK, hyponatremia, other causes, you could treat them. Subclinical hypothyroidism, that is anything between 7 to 10. 5 to 7 is still debatable. The antibodies are negative, TSH is marginally raised, 5 or 6, you could wait annual follow-up. So it's very simple. Then if you measure the TSH, it's normal. Still you think the patient is hypothyroid. Then you measure free T4. Otherwise, you give it up and measure free T4. If the free T4 is still normal, then think of other conditions, maybe vitamin D deficiency or some other condition mimicking hypothyroidism. But if the TSH is normal or low normal and a free T4 is low, that's where you should go for pituitary testing, evaluate pituitary, or it could be just the history, sick euthyroidism, or drugs like steroids, which might just suppress both TSH and the free T4. So these are common things that could happen, but it's good to know some rare causes also, when to investigate, not to over-investigate as well. Scale of things, TSH rises early in the course of the disease, then the free T4 falls, and then ultimately the T3 will fall. So I don't recommend testing T3 to diagnose hypothyroidism at all. All what you need is a TSH to start with. If you are treating, get a free T4. So how do you treat? It's very simple. Many causes, just one treatment we have, levothyroxine. Other countries in UK, they have T3 also, but this part of the world, we don't have T3. We treat with T4, which gets converted in the body to T3, the active form. 1.6 micrograms per kg per day is the general dose. First thing in the morning, empty stomach. You have to wait for at least half an hour to 40 minutes to have your meals. That is a must. That's where we get it wrong if you don't give the instructions to the patients. Every 6 to 8 weeks, you monitor the TSH and try to get it to the normal levels. Patients with heart diseases and cardiovascular risk factors, start low and go slow. 25 micrograms, escalate every 4 weeks, check the ECGs, symptoms, they are tolerating well, go up slowly to the maximum tolerable dose. If you are treating children and young kids, the body weight dose is more. You can follow this algorithm and decide on the dose depending on the age. Then come down to 1.6. The target should be anything between 1 to 2.5 and T4 in the upper quartile. Then, of course, you look at the symptoms and slightly vary the dose depending on the response rates. So T3, just for theoretically in UK, some patients are not happy with T4. Sometimes in midday, they say they are getting symptoms. There are regimes where you can, if T3 is available, you can add a small dose of 20 micrograms of T3 at lunchtime, but it's complicated. we treat with T4, vast majority will respond well. If things are not good, you are giving 2 micrograms per kg per weight, and still the patient TSH is not coming down. Patient is having symptoms, what do you think? So could be reduced absorption, malabsorption syndromes, or any of these medication interfering with the absorption, or drugs affecting the metabolism, which is metabolizing the levothyroxine, and you are not getting the effect. Again, think about compliance and then take corrective measures if things are not corrected with this thing. So if you get it right, it's a very rewarding disease to treat. Within 2-3 months, your patients will be very happy and back to normal. In pregnancy, Sri Lanka we have done, got our own levels of TSH for each trimester. I don't know about you, this thing, but you must refer to your lab and get your normal levels, which are TSH is generally lower in the trimester. Somebody on thyroxine, moment they are pregnant, please increase the dose by 25% and then monitor them closely. Subclinical hypothyroidism, the ATA guidelines, TSH more than 10, free T4 normal, still you treat. 7 to 10 with antibody positivity and any other reason, symptomatic, you could treat. 5 to 7 is very debatable. You take a clinical call and then start with a lower dose and go up on the dose. So in the next 6 minutes, I'll have to cover hypothyroidism. So I have summarized the common causes of hypothyroidism here, the commonest being Graves' disease, diffuse goiter, increased vascularity, increased uptake in the uptake scans, iodine or technetium, and TSH receptor antibody positivity. So these are the commonest thyrotoxic features. Then, of course, you'll get the toxic multinodular goiter and the other causes as mentioned there, and their findings. I have summarized this in the interest of time. So let's get on to the TSH is still enough to diagnose hyperthyroidism, suppress less than 0.1%. Still you could diagnose, then you do a free T4 later, but it could be also low in secondary hypothyroidism, pregnancy as shown, and if there is an abnormal antibody binding. TSH may be high in hypothyroidism, obviously thyroid hormone resistance and TSH-OMA. What's the difference? Very rare things. TSH-OMA, patient will be clinically thyrotoxic, and in thyroid hormone resistance, mainly they'll be hypothyroid, but the TSH will be high. So you need to, these are rare instances that you should. So that's why I said the tests are not agreeing with each other and the clinical features are not agreeing with the test. Then think about rare causes, antibody interference, heterophile antibody, or rare causes like TSH-OMA or thyroid hormone resistance, which is out of the scope of this lecture. But if you do ultrasound, simple ultrasound, diffuse goiter, and you say what you call, if your radiologist says there is a thyroid inferno, unless otherwise proven, that is Graves' disease. Of course, the uptake scans, I don't know the availability here, but this will be very useful to differentiate most of the causes, common causes of hyperthyroidism, as shown here, increase uptake in these conditions and reduce uptake in the conditions mentioned there. Thyroiditis, that is a very useful test to differentiate between thyroiditis and early Graves' disease. So let's look at some scans. This is a normal scan, uptake, iodine uptake. This is Graves' disease, increase uptake. Subacute thyroiditis, reduce uptake with increased ESR, tender goiter, diffuse goiter. You don't need anything, some steroids or painkillers would do. And this is a toxic adenoma or a nodule. So you have all this diagnosis with one scan, you can decide on the treatment. Rare instance of a struma ovary, just for your interest, thyroid is normal, thyroid, it's produced in the ovaries. So how do you approach? The clinical features are given here again, tachycardic, losing weight, tremors, eye signs, lid lag, lid retraction, and exophthalmos and thyroid eye disease associated with Graves will be diagnostic, but so many things will be there. Remember, apathetic hyperthyroidism in the elderly. They might look depressed or detached, but still they can have hyperthyroidism called the apathetic hyperthyroidism, especially in the elderly. So this is the algorithm that you follow. Commonly, TSH suppress, increase free T4, primary hyperthyroidism, no debate about that. TSH suppress, free T4 normal. That's the indication to do a T3, which 5% of the time you might find a T3 toxicosis. And if the free T3 is also normal, it could be subclinical hyperthyroidism or some antibody interference you have to think about. And of course, the TSH is normal or high with the increased free T4 could be a TSHoma, a very rare instance. And the Graves, I mentioned the things. And if you see somebody with these features, exophthalmos with the clinical activity score, high redness, swelling, tearing, chemosis, all that, pretibial myxedema on the corner, and thyroid ectropathy. That is, unless otherwise proven, it's Graves' disease, the commonest cause. Then in the next 2-3 minutes, I have to go through the treatment options. It's mainly medical. We have carbimazole, propylthiouracil. I don't know whether you have methimazole in India. And then beta blockers, verapamil or diltiazem would be helpful to control the heart rate initially and the sympathetic overactivity. Then we have radioiodine treatment and surgery for very large goiters, which is suspicious of malignancy, non-compliant patients, and severe Graves' disease with ophthalmopathy. We could, and relapse patients after, medication, we could think about surgery. We have 2 drugs, propylthiouracil, carbimazole, and maybe methimazole if you have it in India. It blocks the thyroid peroxidase enzyme and reduces the levels. PTU has extra action of blocking the peripheral conversion of free T4 to T3, which is useful in a peristorm or very severe thyrotoxicosis. Initial stages, PTU is the drug of choice, and first trimester of pregnancy. We use PTU. Now carbimazole is approved after the second trimester. You could use carbimazole, but first trimester you could use PTU. We had the earlier block and replacement regimes, but now what I recommend would be a titration method where you give a higher dose and then titrate it down over the next couple of months, anything from 6 to 18 months. You can try medical treatment, tailing off, higher maximum dose of 60 milligrams of carbimazole or 600 milligrams of propylthiouracil, with reducing the doses gradually if you can achieve a remission. Otherwise, go for second line treatment. Until TSH monitoring, you should monitor free T4 initially until the T4 is normalized. When it is in the normal range, you could monitor with TSH. Otherwise, sometimes TSH will be 0.001 every time you do it. You have no idea what to do. So monitor with free T4 initially, high dose. Once the T4 is in the mid-normal range, shift to TSH and not try to normalize that. And then you stop the medication. Relapse rate is high, then we go for the second line treatment. And those who are unlikely to go into remission would be a large goiter, multinodular goiter, severe biochemical hyperthyroidism, males, and in very young and the old extremes of age. Side effects, agranulocytosis and rashes, you all know. Don't use the drugs interchangeably. Rashes, you could use the other drug and try, but not for agranulocytosis. This happens usually within the next first 3 months of treatment. PTU has an added hepatotoxicity. And just a word about transient gestational thyrotoxicosis, where you have a beta HCG effect, or alpha subunit is common for both TSH and beta HCG, which stimulates the thyroid gland and have a mild thyrotoxicosis, but you can see the differences. TRAB antibody in pregnancy would be a good test to discriminate between early Graves and transient gestational thyrotoxicosis. Just take a photograph of this in the interest of time. ATA guidelines in treating subclinical hyperthyroidism. If the TSH is less than 0.1 and if you are more than 65 years, no symptoms even, you have to treat. Risk of atrial fibrillation, osteoporosis, and other this thing. Other cases you could consider, depending on the comorbidities, you could consider and treat. So these are the ATA guidelines for that. I don't have time to just one for the road. Just note down this scenario, normal TSH and high free T4, what it could be. It's just thyroid hormone resistance, but you have to do lots of other tests. Just one for the road to create the interest in you. Thank you very much.